Good afternoon, everybody. Maybe good morning or good evening for some people, depending on where you are in the world. Welcome to the webinar organized by the European Reference Kidney Network for Rare Diseases. My name is Elena Levchenko. I'm a pediatric nephrologist from Leuven, Belgium, and I will moderate this webinar for you today. I'm really happy to introduce our speaker, Professor Tom Nijenhuis from Nijmegen, the Netherlands. He is one of the rare adult nephrologists who is very much interested in rare kidney diseases. He is a full professor of rare kidney diseases in Radboud University Medical Center in Nijmegen. He is working during many years on different rare kidney diseases and got several awards for this. He got the Best PhD award when he studied the epithelial calcium and magnesium channels in different rare kidney diseases, so it was some time ago. And then he was awarded by Dutch Kidney Foundation as a junior and senior golf career stimulation awardees, and he's very active in the ERKNet as an adult nephrologist in the tubulopathies working group, but also in many other working groups. So Tom will present today on the topic of Gitelman Syndrome, mainly in adults. And it's also very nice that we started with a new tradition in ERKNet webinars to invite patients having the disease. So we will have a patient voice today. So very much welcome to our webinar. Now I will switch off my camera and my microphone, but please be active for questions. You can ask your questions using the questions part of your attendees panel. So very much welcome, and Tom, please start your presentation.
Okay, thank you, Elena. Thank you, everybody. I am, as Elena said, Tom Nijenhuis. I'm an adult nephrologist from Nijmegen, and I'm very glad to give this presentation today on Gitelman syndrome, and especially on the adult view. And maybe you can remember that in October of last year, we had a presentation of my colleague Martin Conrad, who's a pediatric nephrologist, on Bartter's and Gitelman syndrome in the pediatric or with a pediatric view. Let me see if I can switch the slide. Yeah, here it is. So Gitelman syndrome, of course, is a renal tubulopathy. And I always start my presentations for students with this slide to underscore how important these renal tubules actually are. Because, and I've calculated this some time ago, if we would not have these renal tubules, we would lose 180 liters of water per day, about 1.5 kilograms of table salt per day, the potassium equivalent of about 48 bananas a day, the calcium equivalent of about 7 liters of milk a day, and the magnesium equivalent of about 2 kilograms of almonds per day. And of course, you can imagine that we cannot, that we need these tubules because we cannot correct this just by eating this much. And if you think that I am completely ignorant to the important role of the tubules for acid-base homeostasis, I guess I just was a bit lazy in calculating how much baking soda you should eat if you would not have any renal tubules. But at least Gitelman syndrome is also a tubulopathy, and it is a salt-losing tubulopathy, which is actually, I'm not seeing my pointer here, but we can do without. So it's a salt-losing tubulopathy, which is actually in the distal.
We can see your pointer actually, so you can use it.
Yeah. Oh yeah. The interesting thing is that that I cannot see my pointer. So I'll not use it because I'm not knowing because I'm not seeing what I'm actually pointing at. But at least Gitelman syndrome is located in the distal convoluted tubule, and I've depicted here a distal convoluted tubule cell with some of the transport mechanism which are in this tubule cell. And on the apical side is also the sodium chloride cotransporter. And it's actually this sodium chloride cotransporter, which is encoded by the gene SLC12A3, that is mutated in this autosomal recessive disorder. and therefore, let's say the sodium reabsorptive capacity of the distal convoluted tubule is hampered, and you lose sodium in your urine. And actually, this loss of sodium in your urine is a problem because salt-losing nephropathies and salt-losing tubulopathies actually lead to a hypokalemic alkalotic phenotype. And they do this because this loss of sodium chloride, in this case in the distal convoluted tubule, and Gitelman syndrome, which is actually a bit like a chronic thiazide diuretic user, because this sodium chloride co-transporter is actually also the molecular target of the thiazide class of diuretics. And with this, you lose salt. This leads to increased distal tubular flow and sodium delivery to the epithelial sodium channel, which is in the collecting duct, depicted in purple here. And also, let's say the loss of sodium chloride leads to a lower extracellular volume, which increases your renin-angiotensin-aldosterone system, increases aldosterone, which furthermore stimulates your ENaC. And this actually looks to be a good thing, because in this way you can compensate for some of the sodium chloride that you are actually losing by increasing sodium chloride reabsorption in your collecting duct, but you do this at the expense of the loss of potassium and hydrogen ions, and thus a hypokalemic alkalosis. So that is a hallmark of this disease. It's a salt-losing hypokalemic alkalotic disorder. And there are more hypokalemic alkalotic salt-losing tubulopathies, for instance, the Bartter syndrome. I will not go into the molecular detail now, but this is a similar disorder, only there the problem is in the thick ascending limb of the renal tubule. There also your sodium chloride reabsorption is hampered. In this case, it is the sodium chloride reabsorption mechanism that can also be affected by using loop diuretics. So in this case, you could say these are the chronic loop diuretic users or the genetic loop diuretic users, but also there you see an increased sodium chloride coming into your collecting duct, a low extracellular volume, and thereby compensatory sodium chloride reabsorption there, but at the expense of potassium and hydrogen ions. Well, what other clinical signs are there in Gitelman syndrome? Well, like I said, hypokalemic alkalosis, but you also see a renal hypomagnesemia. And if I could see where I was pointing, I would point here at the epithelial magnesium channel that is called TRPM6 in this slide. And actually the transcellular active magnesium reabsorptive capacity is also in these distal convoluted tubule cells. And the idea is that the loss of the sodium chloride co-transporter hampers these cells and might even lead to an involution of the first part of the DCT, the DCT1, which reduces your magnesium reabsorptive capacity, and therefore leading to increased magnesium losses through the urine, and thus hypomagnesemia. Another hallmark of Gitelman syndrome is hypocalciuria, so a low calcium in the urine. I will not go into the details of the mechanism here, but very broadly, this could be either due to the fact that due to the extracellular volume decrease, you not only increase your sodium reabsorption in the collecting duct as a compensation, but also more proximally, and thereby you also reabsorb more calcium together with sodium that is reabsorbed over there. Or there is a direct link to the active calcium reabsorption, which also resides in the distal convoluted tubule. And I think the jury is still not out on this mechanism. And of course, because you have sodium loss, low extracellular volume, these patients tend to have a normal to low blood pressure. So hypokalemic alkalosis, renal hypomagnesemia in, I think, most of the patients, hypocalciuria, and a tendency to have a low blood pressure. So what signs and symptoms does this now give? Well, this is a table from a KDICO controversies conference paper from about 5 years ago, and it sums up different signs and symptoms that patients can have in Gitelman syndrome. And if you look at the left bar with the most common symptoms, then you see here cramps and muscle weakness, probably due to the electrolyte disorders. A lot of patients complain about fatigue. Patients also have salt craving, so they tend to eat more salt, which is probably because your body is actually telling you that you are salt losing. Things like dizziness, maybe something to do with the low blood pressure, paresthesia, numbness, palpitations, and let's say symptomatic low blood pressure. The interesting thing is, if you see this graph, you would say that this is a rather impressive set of signs and symptoms. But in literature, Gitelman syndrome is often described as a mild phenotype, and whereas in some patients that may be true, I think that mild is relative, and it's especially relative because Gitelman's is also always seen in this spectrum of, let's say, antenatal Bartter syndrome to Gitelman syndrome. And then maybe relative to the other disorders, it might be mild, but if you see this table, it does not seem mild at all. But who am I to say? And therefore, it is very good that we have a Gitelman patient with us today, because I think the patient voice here is important, and I think that she can attest to the impact that Gitelman syndrome can have on your day-to-day life. So I would like to give the floor at this moment to our Gitelman patient, which because of privacy issues, we have chosen not to name her or to show her on camera.
Thank you very much, Dr. Nijenhuis and ERKNet, for giving me the opportunity to share my experience. So I'm 46-year-old, diagnosed with Gitelman syndrome when I was 39. During childhood and adolescence, I did not experience a lot of symptoms. I was quite healthy, except for a few times that I had like cramps or tingling. And when I was in kindergarten, I was made to the hospital for a few days for checkup, and after supplementation of magnesium and some checkups, regular checkups of blood, everything went back to normal, basically. So I did not have regular checkups or medications or supplements at that time. And maybe go to the next slide. Thank you. So during my adult age, I started to develop severe symptoms in the 30s, and I think it was probably because of exhaustion physically. And since then, I'm taking potassium and magnesium and to supplement the shortage. And my health was quite good for about 9 years. No major health symptoms related to Gitelman syndrome, and I also had I didn't have any regular checkups, probably twice. And so it all went well for a long time. And then about 6.5 years ago, I had a relapse, and there was also the time that I did the DNA test. So it was diagnosed that I had Gitelman syndrome. Sorry, the DNA test. From that time on, the medication, the supplements dosage had to be increased, and I started taking medication as well for reabsorption of the minerals. And I am having regular checkups, health checks since then. And the big change from the years before is that the energy levels decreased, and it took a long time for me to recuperate. So let's go to the next topic. So the challenges and the needs and concerns that I have, and probably I think a lot of other Gitelman patients share with me, are the ups and downs in physical health, and also emotional health. There's some challenge in that sometimes, because I have to deal with uncertainty and sometimes frustration and anxiety and not trusting my own body, fear, but also in my case, overcompensation, because I don't want to appear weak, for instance, at work. So yeah, so I sometimes overcompensate, with resulting in exhausting myself again. And then another challenge is every time when I encounter problems with physical health, I need to try to accept the new situation again. So need to be adaptable. I noticed that sorry, my the quality of life has changed. It's sometimes challenging to have a good work-life balance, and of course social life sometimes is different as well in times when health is not that great, and of course social life is not a priority at that moment. And also what I find difficult is dealing with misunderstandings about this disorder. So it's hard to explain what it is in the first place, but also one of the symptoms that occurs quite often is tiredness. And it's hard sometimes to explain like why this tiredness related to Gitelman is different than just normal tiredness or fatigue. And the next challenge I encountered is sometimes it's also hard to explain that so the urgency of when it's not going that way, then it's very important that the blood checks need to be done fast. And so what I would want to say is I think it's really important that awareness will be increased among about Gitelman syndrome among healthcare professionals as well, because it's really rare. So it's not, when I'm tired, it's not like I can just have a rest and then I'll feel better again. Sometimes that's sufficient, but it can also mean that maybe there's something wrong with mineral levels, and that there's urgency. And another thing is I noticed that like my sister has it as well, and probably my brother too. And also I heard from other Gitelman patients that there's a lot of like variety, like no patient is the same, all very different. And I also noticed myself, like I've had times I worked like a lot, like 40 hours or even 80 hours in a week, felt really great, to not being able to walk up the stairs. So it's so it can be really unstable, and per person is really different. So I think it's really important to to have a personal treatment. And let me see. Another challenge is coverage of healthcare insurance. Not all healthcare insurance companies cover supplements, so that has been an issue. And also to find the right a suitable supplement that will not give too many side effects, and that's different per person. And what I also heard from other Gitelman patients and also experienced myself is sometimes there are delays in medication delivery because of, I heard, for instance, with potassium, that certain material is not available, so that there are delays or even production stops of certain medication. And how much time do I have? So,
well, you can go on and finish the last two.
Thank you. And another question that I have is because sometimes the imbalance happens at night, and then don't want to go to hospital or to have your blood checked. So I was wondering, yes. So what would be really interesting for Gitelman patients if there are any self-tests or self-test to see what your mineral levels are, so you can adjust the medication or your supplements yourself. And the last thing is really curious also to know and to keep up to date about the effect of prolonged low mineral levels. So I'm really interested in also like how can I prevent maybe other problems in the future, like for instance menopause. A lot of things change, and does it have effect on the minerals and so on. So I would like to conclude the presentation here because I think it's time. So thank you very much.
No, thank you very much. And I think that your test at least shows the impacts what this kind of disorders can have on your life. And in all honesty, a lot of the questions that you ask are very valid, and also shows us that for a lot of these questions we actually don't have a good answer yet. So a lot is still to do there. Maybe when resuming my presentation, I thought that it would be a good idea to say something about differential diagnosis and how do we now come up and come to a diagnosis in a patient with let's say a possible diagnosis of Gitelman syndrome. And I guess that most patients actually present with the hypokalemia. That is most often the presenting symptom, and then the alkalosis is soon discovered. So I thought we might start with hypokalemic alkalosis, and if you then look at the differential diagnosis of hypokalemic alkalosis, this actually results from both acquired causes or rare genetic tubular disorders, with the acquired disorders including, for instance, and we now understand why that is, loop diuretics, thiazide diuretic use, but also patients with who are anorexic or have bulimia or who are using laxatives can have a hypokalemic alkalosis. Things like, which is something important in Holland, licorice ingestion, but also hyperaldosteronism. And that the genetic part of the differential diagnosis, you can think of the salt-losing nephropathies like Bartter and Gitelman syndrome. But a very interesting thing is also Little's syndrome, which is actually not a salt-losing disorder, but it nicely shows, let's say, this compensatory mechanism, which is also there in Bartter and Gitelman syndrome, because Little's syndrome is actually a gain-of-function mutation in the epithelial sodium channel ENaC. And therefore, there you have a genetic hyperactivity of this ENaC channel, which leads to more sodium being reabsorbed at the expense again of potassium and hydrogen ions. But of course, this there is no salt losing here, but rather an increased reabsorption of sodium chloride. So this actually leads to hypertension and not so much to hypotension, as you can see in Gitelman syndrome. So I already crossed out here the hypertensive disorders. Helping us a little bit in differential diagnosis, because we measured blood pressure in our patients, and she or he had a lowish blood pressure. And then if you want to see whether there are actually gastrointestinal losses or renal losses, you can, and this was beautifully shown in this paper by Wu et al. Recently. You can look at urine biochemistry, and let's say generally when you have a gastrointestinal loss, you would expect that your urine sodium and chloride would be low, of course, because you try to compensate, let's say, the loss of either sodium and chloride or both from your gastrointestinal tract. And in renal losses, you would expect high urine sodium and chloride levels. But it's also interesting that if you have a gastrointestinal loss, let's say the sodium chloride ratio in your urine can actually tell you where you are losing which ion, because if you are anorectic or bulimic, then you lose gastric juice, and gastric juice contains more chloride than sodium. So eventually there will be less chloride than sodium in your urine. In the situation of laxatives, it's the other way around, because stool, which you lose with diarrhea or laxatives, actually contains more potassium and sodium than it does chloride. So in that case, you have less sodium than chloride in your urine. So this can help you in differential diagnosis. When you are taking diuretics, or you actually have a very rare salt-losing nephropathy, then your urine sodium chloride is actually coupled. So the ratio of your sodium concentration, chloride concentration in the urine is actually more or less the same. And the interesting thing with diuretics is, because some of these patients that present with the possible diagnosis of Gitelman syndrome are actually taking thiazide diuretics, but they are just not telling you, is that if you do multiple spot urines, then with diuretic use, you would expect that you have a coupled ratio, so let's say a ratio of about 1, but that at certain times you will have a high sodium and chloride concentration in your urine, but also in the situations where the effect of the diuretic has run out, you expect your kidneys to compensate and to collect the sodium and the chloride again. So then you often see variably high and low urinary sodium and chloride levels. So that can also help you, and that is what you actually see depicted in the graph at the left. So after we looked at that, and you can also look at thiazide and loop diuretics in the urine or in the blood, then eventually we come to the situation where we think that there might be a genetic rare tubular salt-losing disorder in the patient. And then I come back to this K-Digo controversies paper, where there was a very nice table with diagnostic criteria for Gitelman syndrome. And there it says, well, the criteria for suspecting a diagnosis of Gitelman syndrome is actually, well, the things that we already said: hypokalemia, alkalosis, hypomagnesemia, which is present in the majority of patients with Gitelman syndrome, hypocalciuria, and that is important because, for instance, let's say in Bartter syndrome, you classically expect a hypercalciuria and a hypocalciuria. So this helps. Of course, you expect high plasma renin activity or levels because of the renin-angiotensin-aldosterone system being activated. Low to normal low blood pressure, and a normal renal ultrasound. And why that is important is that, let's say, in the Bartter phenotypes, you have hypercalciuria and a tendency for nephrocalcinosis and kidney stones. And then they say that an important criteria for establishing the diagnosis is a genetic confirmation of the biallelic inactivating mutations in the SLC12A3 gene. But the paper actually also has a table, or it is actually in the same table, showing features that are arguing against a diagnosis of Gitelman syndrome. And this might seem odd at first, but I will tell you why this is important. And of course, this contains the use of thiazide diuretics or laxatives or whatever. It also contains a family history of a disease transmitted in an autosomal dominant mode, which actually makes sense because Gitelman's is autosomal recessive. Of course, absence of hypokalemia, absence of metabolic alkalosis. If you have renal ultrasound changes, hypertension, prenatal history of polyhydramnios or hyperechogenic kidneys, because then you would think more or less along the lines of the antenatal Bartter syndromes. And Gitelman syndrome is most often presented, let's say, in childhood, during adolescence, or even at adult age. I have had patients which were diagnosed at 50 or 60 years of age, but not before the age of 3 years, most often. Well, why is that? Why is this table actually important? Because we now know that there is not only Gitelman, but there are a couple of Gitelman-like tubulopathies out there. So this graph shows the signs and characteristics of Gitelman syndrome. So mutations in SLC12A3, autosomal recessive, alkalosis, hypokalemia, hypomagnesemia, hypocalciuria, lowish blood pressure. But also, let's say, in Bartter syndrome, and you might know this slide because this slide was also in Martin Conrad's presentation in October, where he actually talked about Bartter-like syndromes, and that's a little bit the difference between the adult and the pediatrics view. Pediatrics think these are Bartter-like syndromes, and adult nephrologists think that these are Gitelman-like tubulopathies. But he actually showed that you have different forms of Bartter syndrome, so antenatal Bartter syndrome, which is actually caused by mutations in the NKCC2 co-transporter or the ROMK potassium channel. But you also have what is classically called classic Bartter syndrome, which is because of a mutation in the chloride channel CLC-KB. And we actually know that these patients, which we call Bartter syndrome type 3, with these CLC-NKB mutations, also show, of course, a hypokalemic alkalotic phenotype, because that is also the phenotype of Bartter syndrome. And of course, they can show hypocalciuria and nephrolithiasis, nephrocalcinosis. But a part of these patients actually shows hypomagnesemia and a hypocalciuria, so they can have a clear Gitelman phenotype. And that is probably because this chloride channel is also expressed in the distal convoluted tubule and is actually involved with the sodium chloride reabsorption also in this part of the tubule, which actually makes it rather logical that this might also lead to a Gitelman-like tubulopathy. But also in the distal convoluted tubule cells, there are other mutations, for instance, mutations in the transcription factor ERKNet beta, or which again regulates the gamma subunit of the sodium potassium ATPase, in which you can also have mutations. And we know that these kind of mutations also can lead to a Gitelman-like tubulopathy. For instance, in these ERKNet beta patients, as you might know, this can also lead to the disorder ADTKD, where you have reduced kidney function, where you have diabetes, where you have gout, renal cysts, etc. But part of the phenotype can be a Gitelman-like tubulopathies, but this phenotype can be very variable, and there are indeed patients that have only the Gitelman-like tubulopathy. But of course, there the inheritance is autosomal dominant. But otherwise they can look very much like a Gitelman patient. And the same actually also holds true for patients with mutations in the gamma subunit of the sodium potassium ATPase encoded by the FIXIT2 protein. Also there you can have a phenotype that very much resembles Gitelman syndrome. And in a paper published only a couple of months ago, we showed with a lot of European colleagues that also mutations in mitochondrial genes, MTTI and MTTF, can actually lead to a Gitelman-like tubulopathy, which can look very much like the classical Gitelman syndrome. So is there any way to differentiate these diseases clinically? Well, in the past, we used a thiazide test. And why did we use a thiazide test? Well, that actually makes sense because in Gitelman syndrome, you have a mutation in the thiazide-sensitive sodium chloride co-transporter, which means that the effect of thiazides in these patients would be reduced. And this thiazide test was set up in the past, and these authors clearly showed that if you look at the difference in maximal fractional excretion of chloride, that you can nicely differentiate between controls, which have a change in fractional excretion of chloride of above 2.3%, and Gitelman patients, which are almost all below this threshold, whereas the Bartter patients are above the threshold. So they said, well, this test actually has a sensitivity of 93% and a specificity of 100%. Of course, in the population that was tested, which were genetically proven Gitelman and Bartter patients. But does that still hold true? Well, we also tested, let's say, the other patient groups with these thiazide tests. And again, we saw that the controls all tested above, let's say, the cutoff of 2.3%. So everything is well until this. Also, our Gitelman patients showed a reduced response to thiazide, which is what you would expect. The one Barter patient that we could include showed an exaggerated response to thiazide, which is also what you might expect. But if we then looked at these HNF1 beta tubulopathy patients and the one patient that we could get in the study with a FIXA2 mutation, also these patients can show a reduced response to thiazide. And in the 2022 paper on the mtDNA mutations, we also did thiazide tests in a subset of these patients, and we could show that 1 out of the 5 patients tested clearly had a reduced response to thiazide. So this thiazide test is actually not a good test to diagnose Gitelman syndrome, and especially to differentiate between the different Gitelman-like phenotypes. And the other interesting thing is that there are also acquired Gitelman-like tubulopathies, of course, chronic thiazide treatment. But I also found this paper from 2006 interesting. I see that I forgot to put in the reference. But here they show that Gitelman syndrome can also be a result of cisplatin therapy. Of course, we know that cisplatin has an acute effect and can have electrolyte disorders, especially very crude hypomagnesemia. But here they describe a 42-year-old woman which presented with a 20-year history of hypokalemic metabolic alkalosis, hypomagnesemia, hypocalciuria after cisplatin-based chemotherapy. And I completely agree. The only thing that I don't agree with is that they say that this seems to be ultra rare, because they say only 13 of these patients have ever been described in the literature. Well, at our hospital, we have this specific outpatient clinic for late effects of chemotherapy. And I must say that I have seen several different patients which had cisplatin therapy in the past, and they had a phenotype that was indistinguishable from Gitelman syndrome. And even in 1 or 2, we did genetic testing to be sure that because they had the cisplatin treatment very early in life, to be sure that they did not have, let's say, a genetic rare salt-losing tubulopathy, namely Gitelman syndrome. So that makes me come back to this table with diagnostic criteria, because if you want to establish the diagnosis of Gitelman syndrome, you need to do genetic analysis, and you need to show biallelic inactivating mutations in SLC12A3. So genetics establishes the diagnosis, but also dictates nomenclature. And why is this latter part important? That's important because in the past we said, well, this patient had a phenotype of Gitelman syndrome, and when we did not do, let's say, genetic workup routinely, then, well, all these patients had Gitelman syndrome. And at a certain point, we knew that, for instance, Barter syndrome type 3 could look like Gitelman syndrome. And then we started doing more and more genetic analysis. And then I know that let's say 10, 15 years ago, I was writing letters about these patients saying, well, this patient has a phenotype of Gitelman syndrome based on a mutation in the CLC-NKB chloride channel. And I think nowadays we should say that genetics dictates nomenclature. So a person with an SLC12A3 mutation has Gitelman syndrome. A person with a CLC-NKB mutation has Barter syndrome type 3, of which we know that it can look like Gitelman syndrome. So switching to treatment, our patient already also alluded to that might be difficult. The first and foremost important thing is to realize that this is a salt-losing disease. So we advise our patients to take sodium chloride ad libitum, which means, and like I said, they have salt craving, so their body is already telling them that they need to compensate for the salt losses. But this is important because there often are people close to these patients, or even well-willing general practitioners, that actually tell these patients, listen, you have a kidney disease, you need to moderate your salt intake. And that is absolutely not true, because they are losing salt. So these are actually the only patients that should take sodium chloride liberally. And then the next question is, should we only tell them to eat salty foods, or should we pharmacologically supplement sodium chloride? And that is something that we are at the moment trying to piece out, because there's not that much literature about that. And for that, I would like to show you two patients that I actually treated with sodium chloride. The patients at the left, patient A, is a patient in which I kept on increasing the potassium supplementations that we are giving these patients, which is actually the red line in the graph, without actually increasing serum potassium levels, which is the bluish line in the graph. Up until the moment where I started to supplement there with pharmacological or extraphysiological levels of sodium chloride, and then all of a sudden I could raise the sodium potassium from 2.5 to above 3. Something similar you see in patient B on the right. This was actually a patient that was that had a rather fair serum potassium level of above 3, but who could not tolerate the potassium supplementation anymore. So what we did there is we reduced the potassium supplementation to about 1/3 of the initial dosage, but also gave the patient sodium chloride. And as you can see, sodium potassium levels, even though we reduced the potassium supplementation, actually increased. So we thought that this was very encouraging. So what we are doing at the moment, together with our colleagues in Rotterdam and in London and in Naples, is that we are doing N-of-1 trials, which are actually randomized, placebo-controlled, double-blind crossover trials in single subjects, where we test sodium chloride next to placebo, and these patients get 12 grams of sodium chloride per day extra in different treatment blocks. And there we look at serum potassium, but also at personalized symptom and quality of life scores to see whether this actually helps, and to provide evidence that supraphysiological pharmacological salt supplementation is a good idea in these patients. So increased salt intake. Of course, we supplement potassium. If there are acute and severe symptoms, you can do that intravenously, but that's not very handy if the patient is outpatient. So eventually you will have to do that with oral potassium supplementation, preferably potassium chloride, because the patients lose chloride, of course, in a slow release formulation. If that is not enough, then there are other possibilities which are not first-line therapy, at least in my view, which are potassium-sparing diuretics. But we should realize that these work, but these also aggravate the salt wasting that is already there in the patient. Another option would be using indomethacin, which has also been shown to increase potassium level in these patients moderately, but also has the downsides of maybe being nephrotoxic if you use it for a long period of time. And actually, our colleagues within ERKNet have set up a survey to look at whether this actually occurs, whether, let's say, patients, in this case with Bartter syndrome, that were treated in childhood, actually show a decreased kidney function whilst adult. Of course, you could also think about RAS inhibition. That might also work, but again, this has a similar downside like the potassium-sparing diuretics, because you are already you have a patient that is already has the tendency to be hypotensive, and you could induce symptomatic hypertension with this. And of course, you have to correct the hypomagnesemia, because we know that with a low magnesium level, it is more difficult to correct potassium. Well, what goal should we then strive for? Well, again, this KDIGO conference has set a goal of above 3.0 millimoles per liter, and I think that is a very sensible goal because that is safe. And let's say experience dictates that it's very difficult to normalize serum potassium, so to get above 3.5 in these patients. And in addition, like I said, we have to correct the renal hypomagnesemia if it's there, and it's there in the majority of the patients. Again, with acute and severe symptoms that seem to be the result of a low magnesium level, you can do that intravenously, but in the long term, you have to do that orally by oral magnesium supplementation. Are there any other possibilities there? Well, I think not. It is suggested that the potassium-sparing diuretics actually also do something on magnesium levels, but I'm not completely sure whether that is true. And again, also here, normalization is difficult to achieve, and the idea is that a magnesium level of about 0.60 is safe. But of course, if the patient is still experiencing symptoms, you should increase magnesium supplementation until they don't tolerate it anymore, to see whether that helps with the symptoms. Well, what magnesium salt should you then give? Well, this is a table from a paper from 2001, which sums up, let's say, the upsides and the downsides of the different magnesium supplements that can be given. Probably you can't read it because it's too small, but you should not read it as well, because I think in the end, almost all have gastrointestinal side effects, mostly diarrhea, if you give higher dosages. Sometimes they're not available. That's also something that our patient alluded to previously. And let's say this all looks nice in theory, but in practice, I think that both the response in terms of serum magnesium, but also the side effects in the patient are actually unpredictable. And the fact that that is true, we in the past tried to prove that. Again, by doing N-of-1 trials in patients with renal hypomagnesemia, which we supplemented with oral magnesium supplements. I must be honest that these were not all Gitelman's patients, but the results from the patient that I'm showing you this was a Gitelman patient. And what we try to do here is do randomized double-blind crossover trial, again in single subjects, with 3 different magnesium salts: magnesium gluconate, aspartate, and lactate. There we looked at magnesium levels in the blood, but also again looked at patient-specific outcome questionnaires and general quality of life questionnaires. And this is the result of one of the Gitelman patients there, where you can see that actually magnesium gluconate and magnesium aspartate led to the same serum magnesium level of 0.60. But magnesium aspartate was much better with respect to the personalized complaint score and the quality of life questionnaire. And even more interestingly, magnesium lactate, which was worse on these two parameters, actually led to the highest magnesium level. So that means that, and if I show you the results of the other patients, then they look completely different. So in conclusion, you need to have a personalized or individualized treatment approach, which probably takes some trial and error here. So coming back to Gitelman syndrome, I think the most important aspects to remember is that it's a distal convoluted tubule disease, a salt-losing nephropathy, so give them salt, which leads to hypokalemic alkalosis, renal hypomagnesemia, hypocalciuria, tendency to have a low blood pressure. And if you want to confirm the diagnosis, you need a genetic confirmation for that. In the interest of time, I think we should leave it at this.
Thank you very much, Tom. It was really a wonderful lecture. Very comprehensive, very practical, and just thank you for the patient to show us the impact of the disease, which is impressive. And I fully agree with you that the disease really has a great impact, while sometimes it's really seen by many as a mild disease. So we have several questions. I will read it for you, and then you can answer. So the first question is from Dr. Munas. Whether Gitelman syndrome can progress to end-stage renal disease. Are you aware of cases of end-stage renal disease in Gitelman?
I am not aware. Of course, end-stage renal disease is something that happens in the normal population, I would say also. So of course there will be Gitelman patients that reach end-stage renal disease, but I don't think because of Gitelman's syndrome. I think that some of the patients that might have been reported in literature some time ago might also have been one of the other Gitelman-like syndromes, for instance, the HNF1 beta patients, of which we know that they tend to have reduced kidney function and can progress to end-stage kidney disease. Same also seems to be true for these patients with these mitochondrial mutations. But I think classically in Gitelman syndrome, SLC12A3 mutations, that should not progress to end-stage kidney failure. Mm-hmm. And that's also what I'm telling my patients, that they can be, that in that sense, they can be at ease, and that they will not, because of the Gitelman syndrome, be on dialysis or need a kidney transplant.
Okay, so thank you. There is another question is regarding genotype phenotype. So is there a genotype phenotype correlation whether patient having homozygous mutations have a more severe phenotype compared to heterozygous mutation in CLC12A3?
Well, let's say, of course, it's an autosomal recessive disease, right? So to have Gitelman syndrome, you need 2 mutations on both alleles. I'm not aware, or I just can't remember of studies looking at whether you have a worse phenotype when you have, let's say, certain mutations, or whether you are compound heterozygous instead of just homozygous. Let's say patients who are heterozygous for SLC12A3, which there are, of course, because these are the family members of the Gitelman syndrome patients and let's say the children of the Gitelman syndrome patients. These do not, let's say, get Gitelman syndrome, but we do know that they tend to have a slightly lower blood pressure. They might also be protected from developing hypertension. So that might be the only upside of that. I don't know whether that answers the question, but
yeah, I think it's a good answer. So another question is, when you look at the adult population, do you see more Gitelman or Bartter type 3 patients?
I think you actually see more Gitelman patients, but there is of course a bias in there. Because I still think that the type 3 patients might be diagnosed earlier, and maybe in childhood and in adolescence. And at least in the Dutch situation, sometimes these patients go to nephrologists in centers near to the place where they live. So I think that is also why there is a bias in the fact that I see more Gitelman syndrome patients than I see type 3 Bartter syndrome patients. But let's say purely epidemiologically, I would not know. And I also think that there are not very good epidemiological, let's say, numbers on prevalence of Bartter type 3 versus Gitelman syndrome.
Okay. And do you think that some Gitelman syndrome patients can be underdiagnosed, that there are many undiagnosed patients in the population, or they would always present with symptoms at a certain moment?
Yeah, I think there might be underdiagnosed, and that can have different reasons. One of the reasons could be that let's say their hypokalemia is mild, and maybe their signs are mild, and the hypokalemia is suggested to have another cause, let's say. But like I said, I've also had patients that were actually diagnosed in their 50s or 60s. But let's say the patient that we just heard in our patient voice, she actually told us that she was diagnosed at, I think, 35 or 39. And of course, she had already symptoms before, but for some reason, let's say, this had never led to the diagnosis of Gitelman syndrome. So yes, I think that there will be undiagnosed patients out there.
Okay, thank you very much. Many people, thank you for the wonderful lecture, by the way. So I have another question, and the question is whether there are any periods like infection or surgical interventions with a higher risk of electrolyte disturbances.
Well, that's actually an interesting question. Well, I think there are some patients, some publications out there which suggest from an anesthetical view that you, of course, have to take care with these patients, right? So when they need an operation, of course, you need to normalize intravenously potassium, magnesium levels, etc. But I think that is not actually the question. So the question was, are there any surgical interventions in which these patients are particularly at risk? I don't think that is the case. But what is the case, or what seems to be becoming clear, and I actually have a slide on that, is that maybe there is a broader phenotype in Gitelman syndrome, and that actually relates to the question about infections. So there was this interesting paper a couple of years ago that actually suggests that if you look very good at these patients, that they have an increased tendency to have mucosal infections and allergic disease compared to age-matched controls. And that there is also a immunological basis for that, or at least there are immunological alterations there, where there is an increased ratio of T helper 2 to T helper 17 cells. I'm not an immunologist, so I'm not going to tell you exactly what that means. But also that extracellular sodium, potassium, magnesium applied to T cells actually reduces this ratio. But unfortunately, as far as I know, there's not yet a study that actually studied the effect of in vivo correction of sodium losses on this phenotype. But there is let's say that there are indications that there might also be something with immunology, let's say it's this broadly in Gitelman syndrome.
Okay, I think this is a very interesting paper. I must say I have missed it, so I will read it. Very interesting. So I have another question. We are not done yet, so I hope you still have some energy. So another question is a practical question about the target values of potassium. So why we strive to reach potassium of 3 and not 3.5?
Yeah, well, I think that that's a trade-off between, let's say, you want to be safe and you want to be realistic. And the thing is that I think when you are at 3 or above 3, then you are safe, and then you have a buffer. A lot of these patients actually are used to having a chronic hypokalemia, and whilst let's say cardiac arrhythmias, palpitations are mentioned in all these tables, I see it rather, I almost never see that in patients. And I think that is because they are used to it. So of course, if you have these patients on your outpatient clinic and they have a potassium level of 2.8, then your lab calls you and tells you, oh, this is a medical emergency. These patients have a potassium level of 2.8, and then I try to tell them that they shouldn't worry because this patient has had a potassium level of 2.8 for the entire life probably. So I think it's a balance between safety and the reality that you are not, at least a subset of patients, you are not going to get above 3.5. And also we should take into account that you need very high levels of potassium supplementation in a lot of these patients, really lethal. So if your lab is not calling you because of the potassium of 2.8, then probably your electronic patient system is telling you that you are prescribing lethal doses of potassium to this patient. But it is also not very palatable. So a lot of patients complain of stomach complaints. You can actually get ulcera from the potassium, especially from the liquid formulation of potassium. So they don't tolerate it. So I think, let's say this paper actually did a good job in saying, well, we don't need to normalize this. We need to strive for a safe level. Which is, I think, reasonable.
Okay, thank you so much. I was very much interested in your trial, just giving sodium chloride in high doses. So do you think these patients who are eating already a lot of salt, still you might have some benefit by adding extra salt, or and are you going the trial normalize their dietary intake? So I think it's very interesting.
Yeah, no, we are not normalizing the dietary intake. So we are just doing, let's say, a real life trial, saying if we just take these patients, that sounds a little bit strange, but if we just ask these patients to take an extra 12 grams of salt, does that do anything on their potassium level? Of course, we are controlling this by looking at 24-hour urine sodium excretion, etc., to say to in the end be able to say something about whether they actually increased their potassium intake, their sodium chloride intake by these sodium chloride tablets, because you can also imagine that they could reduce their dietary intake because of that they are already getting this 12 grams of sodium chloride. But we decided not to normalize that because that would be a big hassle. That would probably reduce the tendency of patients to go for the trial, because the trial is actually rather long, for 24 weeks. And I think that it's nice that we do let's say a real life trial. And the other thing is that it's an N of 1 trial. So that means that primarily this is a trial setup that will show you whether adding the salt is a good idea for this individual patient. And of course, in the end, we will put all the trials together and see whether there is a general effect in all the patients. But the trial will show you whether adding these tablets has an effect in this individual patient. And if it's not, then we shouldn't add it. So one of the outcomes of these trials could be that it works, but not in all the patients.
Yeah, very interesting, and I think it's very, very meaningful trial. So I think we are running out of time, so it ends me to thank you so much. I think it was a very good, very comprehensive and very practical presentation. So thanks a lot, and thank you all for participating. Thank you.